My name is Bronwyn Cox, and I'm a lead quality nurse consultant for Kaiser Permanente in the quality department for our Northern California regional offices. My primary work is in behavioral health, so I was thrilled to have the opportunity to read and provide a commentary on an article from a team of nurses in Lausanne, Switzerland, titled Prevention and Management of Behavioral and Psychological Symptoms in Patients with Dementia in Acute Care, a Best Practice Implementation Project. This took place at Lausanne University Hospital, one of 5 Swiss tertiary hospitals, which serves as both a primary care hospital as well as a referral hospital for a large part of French-speaking Switzerland. The objective was to implement evidence-based recommendations for the prevention and management of aggression and agitation in patients with dementia in the Acute Geriatric Care Unit, AGCU. The AGCU is a 28-bed unit, and the criterion for admission was ages 75 years and older, have at least one geriatric syndrome, and require an acute care hospitalization. Behavioral and psychological symptoms of dementia, BPSD, can include anxiety, apathy, sleep disturbances, irritability, psychosis, wandering, and agitation, and this can occur in up to 90% of patients with dementia, and is often a normal response to stress and uncertainty. The hospital setting can certainly be an acute stressor for this population and exacerbate BPSD. This can also have physiological and psychological impacts on both not only the patient, but also the care providers as well, meaning the nurses or the patient's family members or care providers. There was a three-phased approach to this project taking place beginning in September of 2018 through July of 2019. Phase 1 was when a core project team was formed utilizing the JBI Practical Application of Clinical Evidence Systems, PACES. They developed 7 audit criteria to evaluate the difference between current practices and best practice recommendations in the prevention and management of aggression and agitation in patients with dementia. Phase 2 included getting research into practice, GRIP. The baseline audit results were reviewed with the healthcare team, and brainstorming to identify barriers to compliance of best practices occurred. For the barriers that were identified, 6 strategies were developed. This included a 45-minute training course that was developed and delivered by a geriatric psychologist. The Cohen-Mansfield Agitation Inventory standardized tool was implemented as well into the EHR, electronic health record. Currently, existing non-pharmacological interventions were also strengthened, such as design of the unit, the use of essential oils, lighting, and other items like that. Documentation of agitation and aggression assessment, risk factor identification, and then the use of non-pharmacologic interventions were also integrated into the routine nursing care. Patient situations were also discussed at staff handoff and the nursing knowledge exchange. And staff were really encouraged to ask for expert referrals, such as a psychologist, psychogeriatric clinical nurse specialist, the CNS, or the psychogeriatric when deemed necessary. And lastly, interdisciplinary meetings among nurses, physicians, and the geriatric psychologist were held to analyze situations and identify further management strategies. Lastly, there was Phase 3, in which follow-up audits were completed 4 months after the implementation using JBI PACES, and they compared compliance to the baseline audits. At the outset, initial performance was poor among the criterion, but follow-up from baseline showed an overall improvement in compliance among implementation of best practices to prevent and manage aggression and agitation in patients with dementia. I appreciate the author's candid discussion of the results. While there were some relative improvements in team compliance of best practices, I really was pleased to learn that they really want to continue working on implementing a new action plan to further this work. I think the increase in nursing education, increased interprofessional collaboration, strengthening of non-pharmacological techniques, and lastly, more involvement from the geriatric psychologists for the AGCU should really be celebrated because those are real accomplishments. In my experience, I have not worked in a facility where we have a specialized unit for the elderly population, such as the AGCU at this hospital. I was also quite surprised to find that the nursing staff members had received little to no training in aggression, agitation management of patients with dementia, considering the specialized population of this unit. In my previous work on a 40-bed med-surg telemetry unit, we had a really diverse patient population that could range from ages 18 to well over 100. And among this population, you often had a patient within your assignment with some neurocognitive disorder. And I too found that difficult to manage, especially when caring for a 4 to 5 patient assignment for a 12-hour shift. Perhaps the authors might consider partnering with the AGCU staff with the psychogeriatric unit staff to really further learn and support one another. I empathize with the nurses, as they've shared in the article, that they did not always feel comfortable caring for these patients, and that they really did face a lot of stress and mental burden and workload. There is no doubt that caring for these patients can be very demanding, and their care can be complex, and the problems do not always have a simple solution. The impact of care can result in increased stress and even burnout for both nursing staff and for the patients' families and caregivers. That's often why we often encourage respite care. I wonder, maybe considering a team approach to caring for these patients would be considered in the future. Or, on the flip side, primary nursing, allowing a nurse to have a primary patient assigned to really truly get to know them throughout their working shifts and build and foster relationships with their families. I really think it is essential to engage the patients' families to further learn about these patients' baseline prior to admission and maybe identify any precipitating factors that could lead to BPSD. Given that this project did take place before the COVID-19 global pandemic, I wonder what the culture of the hospital and the AGC unit was regarding patient and family-centered care. The audit criterion related to involving patients, families, in care planning only increased from 0% at baseline to 14% at the follow-up. Were there strict visitor policies in place, or was the family welcome to be present 24/7? While I read this manuscript, I also found myself thinking about how this project could be translated to other settings. I think future research on this topic would benefit any unit that could admit patient and care for patients with dementia and Alzheimer's, regardless of their age, because sometimes there's early onset, and they might not be as old as you may think. I really also think beyond other inpatient units that could care for the same patient population, I would also consider healthcare organizations to consider applying this to skilled nursing facilities, long-term care facilities, and even retirement communities with memory care units. I also think this could work to translate to other neurocognitive disorders such as Huntington disease, Parkinson's, and maybe even patients who have had strokes and have neurocognitive deficits from their stroke. Developing the skills to ensure patients at risk for agitation and aggression will serve not only to increase patient safety, but staff safety as well. I also think it is an important topic for us to consider here in the United States, as our baby boomer population is aging. In fact, every year, 10,000 baby boomers will turn 65 years old, and that will occur every day until the year 2030. And caring for this population will require a broad range of services. I hope the authors continue to feel encouragement to continue their work despite the challenges they face, balancing their project on a specialized unit that was also trying to conduct several other projects at the same time. I feel that this is often a common problem that we face in medicine. We're always trying to implement changes aimed at improving our patient quality of care, safety, as well as evidence-based care getting into practice. But sometimes that can be really taxing on the staff of the unit. It would be great to consider collaborating among other researchers to try and find projects that are really complementary to another and try and implement them in groups. So maybe they could all have achieve success by being complementary of one another. I would love to thank Akror Rashid and his colleagues for your contributions to research in the JBI, and I highly recommend the viewers read this manuscript, and I hope you feel inspired as I did.